One day, you may surrender your body to a room full of strangers. A mask will cover your face. Someone will ask you to count backward. And before you reach the middle of the numbers, the room will disappear. Hours later, you will wake up bandaged, confused, and unable to remember the moment a blade entered you. Now remove the mask. Remove the anesthetist, the monitors, the sterile gloves, and every drug that can switch off pain. Keep the operation. That was surgery for almost everyone who lived before the middle of the 19th century. If a limb had to be removed, you did not sleep through it. You heard the surgeon give instructions. You saw the instruments. You felt the first incision, the sawing, the search for arteries, and the stitches afterward. The only kindness was that it might be quick. Imagine London in 1842. An iron wheel has crushed your ankle. The skin is split, the bone is exposed, and after several days, the wound is swollen, dark, and beginning to smell. The surgeon does not have antibiotics, an X-ray, or a laboratory test. He has his eyes, his fingers, and experience. His answer is simple: lose the leg or let the infection climb through your body. You are not choosing between pain and comfort. You are choosing between immediate torture and a slower death. Many patients refused. Some waited until fever made the decision for them. Others agreed, then panicked when they saw the room. They begged, fainted, tried to run, or had to be carried to the table. You agree because you want to live. The next morning, you are taken upstairs. Operating rooms were often placed high in hospitals, where large windows or skylights could provide the strongest daylight. Around the wooden table, rows of students lean forward from steep galleries. They are not there to comfort you. They are there to learn from your body. A surgeon may offer alcohol or opium. Neither can erase what is coming. A folded cloth, a piece of wood, or a leather strap may be placed between your teeth. Assistants stand beside the table, ready to hold your shoulders and hips. This is not because you have changed your mind. Consent belongs to the mind, while escape belongs to the nervous system. The instant steel enters flesh, the body will twist away on its own. We know the result not only from surgeons, but from people who survived. In 1811, the English writer Frances Burney underwent a mastectomy in Paris. She was conscious while several surgeons removed her breast. A cloth covered her face, but it did not hide the movement of the men around her or the flash of metal. In the letter she wrote months later, she remembered screaming through the incision and feeling the blade meet resistance as it cut deeper. The operation lasted many minutes. There was no quiet place inside her mind to escape to. Fainting could interrupt the experience, but it did not necessarily end it. A patient might lose consciousness from shock and wake while the surgeon was still working. George Wilson, a Scottish chemist whose foot was amputated in 1842, later wrote that the physical sensations had blurred with time. The emotional terror had not. What remained was a feeling of darkness, despair, and abandonment by both people and God. That detail matters. Pre-anesthetic surgery was not simply pain at an extreme level, it was the knowledge that everyone around you had chosen to continue while you screamed, because stopping would probably kill you. Most surgeons understood the horror. Their answer was not cruelty, it was speed. No one represented that better than Robert Liston, the celebrated surgeon at University College Hospital. Liston was tall, powerful, and famous for working faster than almost anyone in London. Students brought watches to his operations. A leg could be removed in well under a minute, and his hands moved so quickly that spectators struggled to follow each step. Speed had a medical purpose. Every additional second meant more pain, more blood loss, and a greater chance that shock would overwhelm the patient. Liston reportedly lost about one amputation patient in 6, a grim figure that was still better than the results at many other hospitals. But speed created its own danger. The famous tale in which Liston cuts an assistant, loses both the patient and assistant to infection, and frightens a spectator to death is probably apocryphal. No reliable contemporary record proves that it happened. The reason the story survived is that it feels possible in a world where surgeons raced against suffering with wet hands and sharp knives. And the race did not end when the limb came off. Surviving the table was only the first test. The second began when the wound entered the hospital ward. Doctors did not yet understand bacteria as the cause of surgical infection. A surgeon might move from a dissection to a living patient without properly cleaning his hands. Coats could be worn through operation after operation. Instruments and sponges were reused. Blood on clothing was sometimes treated as evidence of experience rather than contamination. The operating room looked brutal, but the ward was often deadlier. Several days after surgery, the patient might begin to shiver. The skin around the wound reddened. Fever rose. Pus appeared. Some physicians even described thick, creamy discharge as laudable pus, believing it could accompany healthy healing. In reality, the wound could be filling with infection. Erysipelas, septicemia, tetanus, and hospital gangrene moved through crowded wards. In some major hospitals, amputation mortality reached terrifying levels, and many patients who survived the blade died later from fever. The cruelest part was that the staff carried the answer on their own hands. In Vienna, Ignaz Semmelweis noticed that women in a maternity clinic staffed by doctors and medical students died of childbed fever, far more often than women treated by midwives. The doctors also performed autopsies. In 1847, he ordered them to wash with a chlorinated solution before examining patients, and mortality fell dramatically. The numbers were difficult to ignore. The explanation was not yet comfortable to accept. Semmelweis was telling educated physicians that they themselves were transporting deadly material from corpses to living bodies. Many resisted the idea. His work was attacked, his career deteriorated, and he died in 1865 after developing an infected wound. Surgery therefore demanded two victories from the patient. First, survive the conscious cutting, then survive the people trying to save you. And then, in 1846, one operating room became silent. On October 16th, at Massachusetts General Hospital in Boston, a printer named Gilbert Abbott was brought before surgeon John Collins Warren to have a tumor removed from his neck. Dentist William Morton arrived with an inhaler containing ether vapor. Previous attempts at painless surgery had produced embarrassment, doubt, and accusations of trickery. The audience expected another failure. Abbott breathed from the device until he became unresponsive. Warren began to cut. No scream came. There was no desperate movement, no assistance wrestling the patient back onto the table, no teeth crushing leather. A man lay still while a surgeon worked inside his neck. When Abbott woke, he reported only limited discomfort. Warren looked toward the gallery and declared that the demonstration was genuine. The importance was immediate. Surgery had always been defined by a problem that skill could reduce but never solve. The patient could feel everything. Ether did not make the knife sharper or the surgeon faster. It separated the operation from the patient's awareness. News crossed the Atlantic quickly. On December 21st, Robert Liston used ether at University College Hospital while amputating the thigh of a butler named Frederick Churchill. Liston still completed the operation with astonishing speed. Churchill slept through it and, according to later accounts, woke asking when the surgery would begin. For the first time, the surgeon famous for speed no longer needed to race against a conscious man's pain. Acceptance was not universal. Some doctors feared that removing pain would weaken the body or hide signs that a patient was dying. Others treated endurance as a moral test. Military surgeons debated whether an unconscious casualty was safer than a screaming one. Religious objections also appeared around pain relief in childbirth. Then Queen Victoria used chloroform during the birth of Prince Leopold in 1853. A practice critics had called unnatural had now been chosen by the most visible woman in Britain. Resistance did not vanish, but it became much harder to present suffering as a medical virtue. Anesthesia solved the first horror. Infection remained. In the 1860s, Joseph Lister applied ideas about invisible germs to surgical wounds. He used carbolic acid on dressings, instruments, hands, and eventually the air around operations. His methods changed over time, but the central idea endured. A wound had to be protected from contamination. Death rates in his practice fell sharply. Modern surgery emerged when these two revolutions finally met. Anesthesia allowed surgeons to work without torturing the patient. Antisepsis allowed the patient to survive the work. Tonight, somewhere in the world, a person will lie beneath surgical lights while machines measure every breath and heartbeat. A team will open the body, repair something hidden inside it, close the wound, and guide the patient back to consciousness. The patient may remember the cold room. They may remember the mask. They may remember reaching 7. They will not remember the knife. Frances Burney remembered hers for the rest of her life. George Wilson remembered the darkness surrounding his. The people restrained on wooden tables had to purchase survival with an amount of suffering that modern medicine now works to prevent before it begins. That is why counting backward feels so ordinary. The miracle is designed to disappear from your memory. You close your eyes before the first cut, and when you open them, the worst part has already become something that never happened to you.